Good morning, tribe. I hope you guys are doing fabulous. We're here today with a pediatric hospice expert, Tanya, and she's going to answer all of our questions and enlighten us. So good morning, Tanya.
Good morning.
How are you today?
Doing very well, thank you.
Good. So we have a few questions from the tribe and then a few that I just ask all nurses, but how long have you been a nurse?
I've been a nurse for 20 years now.
Whoa. And what did you do prior, and how did that prepare you for hospice?
So right out of school, I went into pediatric nursing and then did some labor and delivery and some NICU. When I moved to New Mexico, I right away started in pediatric ICU, and that really gave me a lot of the foundation that I feel like I'm using presently. And along with, I did some case management too, so I did a lot of discharge planning on the inpatient side, and also I worked for a Medicaid company who helped with discharge planning for their members, and so that gave me some really good experiences as well.
And you did pediatric and adult case management then?
Yes, so I worked primarily with special beginnings, which are pregnant women with a high-risk pregnancy.
Okay.
And then a lot of times took on their infant if they had issues after birth.
Okay. And then that led you into pediatric hospice?
It did.
Okay. How did you know that area of nursing is what you wanted to work in?
Well, I didn't go searching for hospice. Hospice actually found me. I was sitting in a discharge conference where a patient that I had taken care of the mom during pregnancy, and the infant had some really life-altering problems, and she was going to be admitted to hospice. And so I was coming alongside the hospice team as another case manager, and the medical director caught me outside the meeting and said, "What are you doing? Where are you at? And we'd like you to interview for this position," because they were needing a nurse leader at the time. So I walked into that role unexpected.
All right. That's great. Are there differences between pediatric and adult hospice?
Oh, there are actually, and a lot of people aren't aware of those differences. When the Affordable Care Act came about in 2010, it set aside a provision for Medicaid patients that are pediatric for a hospice benefit that is called concurrent care. And so basically what that means is you can have palliative and curative care at the very same time. And so that really means that we have to negotiate with the medical, the MCOs or the Medicaid providers on what they cover and what we cover. Because we're going to get a daily rate to take care of hospice patients. But if you're looking at curative care, that cost is way beyond what we get reimbursed. And we want patients to be able to have what they need through their lifespan, and not to limit that, and pediatric hospice does that very nicely now.
So I guess what are the qualifying factors for entering pediatric hospice if you're still doing curative measures?
Okay. So our medical director still evaluates the patient, and they have to have a terminal diagnosis. So they can have cancer that's in remission, but they're still able to do some palliative cancer treatment. You can see a decline, or the trajectory has been shortened by frequent hospitalizations. So we'll bring them on, and we still certify them for 6 months, but we may have patients on service for 2 years. And so it's a little bit different than adult hospice, that we have a lot of time with those patients.
Okay. Is this a good place for a new grad to start? And if whatever the case is, could you elaborate on that?
Sure. So I think it would be very difficult for a new grad. I in a couple different ways, and I'll try to go into that just a little bit. It's not impossible, but I think it would require a new grad to be very dedicated to crafting their skills, because when you go out in hospice, you go out typically all by yourself. To see the patient, to assess the patient, to do symptom management. You might need to troubleshoot a G-tube or troubleshoot a new symptom, report it back to your triaging, assessing and triaging, coming up with a plan that will work in the home, because the very last thing that we want to do is hospitalize a hospice patient.
Yeah.
and just really troubleshooting with them. However, I think it could be done. We typically are recommending about 5 years of experience for most of our nurses that start with us. But I think it would be useful for new grads if they're really dedicated.
Okay.
The other thing is that we take call. We're a 24/7 service. So right now I have 4 nurses on staff, and we each take a week a call, a week at a time.
Okay.
So from 5 p.m. to 8 a.m., we're answering calls from patients, troubleshooting things, speaking to our physicians. So that requires a little bit of extra dedication that a typical hospital job doesn't require.
Right. So that kind of gives us the next question quite nicely. What kind of experience would you suggest that a new grad get under their belt if this is something they're interested in?
So I think assessment and triage skills are huge. The other thing that I talked about, or that I like to talk about, is dosage calculations and pharmacy skills. We do a lot of symptom management. So we might get a call that a patient is anorexic, not eating, and how do I increase, what do I do about that? Maybe they're nauseated, or maybe their pain's out of control, and we may have to do some quick dosage calculations with our pharmacist and our MD and increase something. And our patients don't typically come into the hospital, so we manage everything from home. So you're really a very independent practice clinician.
Okay. So
symptom management too is really important.
So not necessarily, probably pediatric, but in a unit, in a clinic, what do you think would be best for them to get prior experience?
Well, I think any general peds, or even if they just wanted to do some office work, I think any pediatric experience is helpful. We might have to walk a patient through, they've never replaced the G-tube before. Like, they were dismissed from the hospital, they were taught, but they've never actually had to do it. Mm-hmm. And we may have to walk them through how to replace the G-tube. Or if they don't have a G-tube and we're doing OG or NG feeds in the home, we may have to go out, replace the NG tube. Mm-hmm. And you don't have the nicety of having an X-ray for placement, right? You're going back to your old school checking for placement, and it does require just some good hands-on skills, I think, for nurses.
Okay. It sounds like in a unit would be better than in a clinic setting, depending on what kind of clinic you're in. Okay.
Exactly, yeah.
So what are some things that have helped you in this line of work?
I think really knowing that nobody dies the same, that honoring the wishes of your patients and your families and really allowing them to write the last chapter of their life is very essential. It's vital also in this line of business to take care of yourself. Acknowledging that you have to grieve as well for your patients and your families. And something also I think is keeping an open mind is also very important. We have to be sensitive to many religions, cultures, and knowing if you have a bias, checking it at the door, that you're really there to serve the patient in their time of need. And it really has nothing to do with me or my beliefs, that I'm really there to serve them. And I think that is what I've learned the most over the last couple of years.
Wow. Yeah. And when you say take care of yourself, do you guys have some support services for the staff?
Absolutely. So we mandate a staff support every month for all of our staff. And that's run by our chaplain and sometimes our social worker. And it's kind of a time that we don't typically talk about patients. We talk more about the needs of our staff and what's going on with them. And maybe we identified something. And I have a really wonderful chaplain right now. I can't say, I say a whole bunch of really wonderful things about him because he's really in tune with us. And so he might pick up on a new nurse that's really struggling with something, and he'll bring that out in staff support and we'll talk about it. So it's been really good.
That's amazing. That's so great. I'm glad you guys have that built in as part of your support system for your staff. That's wonderful. What do you think the characteristics that make a nurse successful in the field of hospice?
So definitely compassion. I think with any nurse, compassion is absolute. But really just having flexibility and open-mindedness as well, because like I said, it's not about what your agenda is, and sometimes that's hard for nurses to learn. Like, we go in with, okay, these are my interventions, and we need to do this, this, and this, but really it's the patient's choice and the family's choice. They may not want to do something that's that you think would be really helpful, but it's really their choice. And so just having that open-mindedness and flexibility for your patients is really key, I think.
Okay. What do you love most about working in pediatric hospice?
So wow, I every time I tell people what I do, I kind of get this like shock factor at first, and I really have to backtrack a little bit and explain to them it's not all sad. It's really very rewarding, and it's a very awesome opportunity that I think that we have to be in a patient and family's life. What I love most is that in pediatric hospice, we focus on fun. So we find out what the patient's bucket list is. If they haven't done their Make-A-Wish, we make sure that they get their Make-A-Wish. We make sure that they're out in the community. So we do symptom management. We control their pain, their nausea, all those things. And then we get them out to concerts. We get them out to plays. We get them out to community activities so that they can build memories and build their legacy with their family. And so we really encourage taking videos, taking pictures, so that the families have those things. And being part of that and seeing the nice things that the community does for us and the rewarding, it just makes people happy to know that this child's on hospice, but they're able to keep going. And I think that has been the most rewarding for me, having been, just here a short time, but really seeing that we live and breathe just having fun and making the most of every single day.
That's great. And I think this is kind of intuitive, but what's the hardest part?
So the hardest part actually is when we get a referral really late and we don't have that time. So a lot of times we'll see a patient come on that may only have 3 or 4 days with us. And so you really have to do a lot very fast. So you have to build trust with the patient. You have to build a relationship with the family in order to take care of them in their last few days. And that can be very difficult. I think the reward is really that getting to know them and building some memories with them helps us as well. And I hate that I don't want to seem like it's not best to have a long-term relationship, but it is really rewarding for us when we can really spend some time with them, I think.
Sure.
Yeah. Staff would agree with that.
Sure. One of the viewers said, I've always felt so honored to be a part of the last hour of life with the family, giving the family memories.
Yes.
Yeah.
I agree.
So how do you deal with the passing of children that you work with? I am assuming that the person that asked this question means maybe coping. How do you cope with that?
So ahead of time, I think that in order for me to be present in the time of a child passing and to be supportive to the mom and dad and siblings and the rest of the family, that I start my grieving process ahead of time in order to be there for them. And I think that has really helped. But like I said, we do the staff support every month, and we include our physicians in on that staff support and any other part of our staff that have supported the family. So I think that's really important. So it's not easy. You can't hold that grief in. You really have to figure out a way to deal with it. And I think a lot of times, like if you work in an ICU unit and you have a child pass, you're moving on to the next patient and you're not sometimes grieving. And I think that's a disservice to us. One of the things that my staff have done for inpatient staff is we go in and we do debriefing. So if we've had a relationship with a patient and they end up dying in the hospital, we'll actually go in and try to do some support for the staff as well. So I would highly encourage, if you're working on a unit that doesn't have a way to debrief in some way for a passing of a child, that you ask your chaplaincy service, see if you have a bereavement committee, initiate that, and really try to do that because it can be very hard if you don't.
Yeah.
It can be very hard.
Yeah, that decompression, I recall
Yes.
several opportunities to have that reflection after a traumatic code or something, and it really was helpful. I've had past experiences where the charge nurse doesn't want people to cry with the family, and then others who are okay with that. Do you guys have a certain viewpoint on crying with your families?
We leave open expression to whatever it is that you're feeling. You have to know that we're going on sometimes a 2-year relationship with these families. And so while we have to keep boundaries, I don't tell people they can't cry. Like, your feelings are your feelings, and we have to be supportive. Yes. And there's a job to be done in the moment. But I think if you don't show some emotions, then the families pick up that maybe you're not sincere. And we really talk about having the hospice heart. And just because you don't work in hospice doesn't mean you can't have that compassionate heart. But so I would discourage people from saying, don't cry. I think you need to express what your feelings are in that moment. And that's certainly okay.
Nice. Okay. And then can you tell us about a typical day in your area?
Sure. So we do home hospice. We have other modalities that we can treat patients in, but mostly it's home hospice. And so our visits are routine. We schedule those generally the week before when we see the patient. So sometimes my nurses will come into the office and do some case management. They may be ordering medications, supplies, and then they'll go out and see their patients. Patient visit may be from anywhere from 1 to 2 hours, depending on what's going on with the patient. And then there may be some follow-up phone calls, like if there's new orders that have to be received. So we're the nurse is kind of everything. So we're the clerk, you're the nurse, you're contacting the physician, you're getting new orders. So it can be very complex. So we really try to dedicate a block of time to each patient to make sure that we're staying on top of things. Okay. So we may see 1 to 2 patients a day. Right now, I have 3 nurses that are seeing patients on a regular basis, and we have 8 patients. So the load isn't that heavy, but we have the potential to go up to 14 to 16 patients at times. Now, when we've got an end-of-life situation going on, generally the on-call nurse will be responsible for that patient, and she'll dump her patients off onto the other nurses, and we'll assume seeing her routine patients while she does some one-on-one or some continuous care with that patient. So we're the only hospice, I think, that has an RV that we pull alongside the patient's house so that we can stay close by. And so that requires sometimes that we stay overnight. But that has really led us to be more connected with our families and to give a better, to give the best care. So it's really a best practice, I think, that we are providing for our patients.
That's phenomenal. I didn't know that was an option. That's great. One of our viewers asked, so what is the best routine? Route. What is the best route to be able to get a job with pediatric hospice? There does not seem to be many. And although I saw it once, I've never seen a posting for this sort of position.
So I have a very small staff, so it's very infrequent that a position does come open, but we're really trying something new. The group that I work for is under University of New Mexico, and so we're trying to branch out and to kind of foster some relationships with inpatient nurses, and so we're trying to open up some areas where they could cross-train with us, learn it, maybe just learn the routineness of our visits, and then if we had a flux of patients, maybe they could come in and help us out. And so look for those opportunities if you're associated with the University of New Mexico. But you're right, pediatric hospice jobs are few and far between, and so really getting those skills, and I think if the opportunity is there, it will come to you. I'm hoping. So we're always looking for good nurses. So.
And the person that asked the question was a great nurse and would be awesome in your area. So a question was, do you see most of your patients at home or in the hospital? And you already answered that, but my question to you would be, if and when your patients are admitted, which you said that's rare, but when they are admitted, do you guys continue doing some visits? I know you can't bill for them just because of the crossover. How does that work?
Actually, so Medicare has really asked hospices to go into understandings with hospitals or skilled care facilities to have a general inpatient billing. And so we're in the process of really fine-tuning that with the University of New Mexico. So most of our patients, if they needed to be hospitalized, if we couldn't control their symptoms at home, yes, we would hospitalize them, and we would continue to see them daily, and they'd be billed at a different rate. So that will be available to our patients very soon.
So does your doc continue managing the patient as long as they can in the hospital setting?
So we try our best to not hospitalize them at all.
Right.
But if they have to be, actually they would be admitted to a service, and then we would just kind of come along, not really consulting because we're their primary. Many times they either maintain a relationship with their primary care provider or we provide the majority of their care. But we don't tell them that they can't go to their specialty appointments. So a lot of our patients still go to their neuro appointments, their cardiology appointments, their GI appointments, and continue that curative part of their care.
Okay.
They could have a very large team when they're in the hospital.
Okay. Yeah. Sounds like it. So how often do you see them, and how long, you already answered this, how long do you get to stay with them when scheduled? You said, you can answer that question again, but you kind of answered it.
All right. So we generally see our patients the very first week of care 3 to 4 times, and then it's 1 to 2 times is what's considered a routine. We are available for PRN visits, so available for PRN calls and visits. And then the duration really just depends on their trajectory, really, and what the parents want to do. So we have had patients on service for upwards of 2 years.
It's pretty amazing. Well, that is all of the questions that were submitted. That went kind of fast. Does anyone that's watching still have more questions for Tanya? I have learned so much through this. I think I'm on staff with you.
Well, I think one of the things that maybe people don't realize, and I'll kind of elaborate on, is we are a true interdisciplinary team. So on my team, I have a medical director and attending, a pharmacist, a chaplain, a social worker, and my nursing staff. And then I am required to have volunteers. And so that's another area that if a nurse was interested in hospice, she could always do our volunteer application, get to know us, and then maybe that could roll into a job. We've hired several nurses that way before. But we meet every 14 days to discuss the patient's plan of care. And when we're sitting there at that table, everyone has an equal say and an equal role in developing the patient's plan of care. And so I think that's one of the most unique interdisciplinary teams that I've ever seen, that there's no hierarchy. The physician doesn't rule all, she takes in what we say and we decide as a team, yes, we're going to move forward with offering this to our patient. That being said, when we walk out the door and we present this to the patient, we give them a choice. If they're not ready for something that we're suggesting, then we go with what they're comfortable with. Mm-hmm. And so it's really just a very interesting, unlike hospital that I've ever had an experience of, but it's very rewarding. So really enjoy my work with hospice.
That's awesome. Yeah. Do you have any other enlightening facts about hospice that you would like to share with us before we conclude?
I can't think of anything. I think we've talked about a lot of it.
Yeah.
Just know that we don't ever give up hope, and we try to just really come alongside parents and make them feel comfortable with the care that they're receiving and give them options to care. And really it's just a very rewarding job. And I think a lot of people, this is horrible, but I think we've been labeled as the death squad, but we're really not. We really love to have fun with our patients. And I wish that mindset could kind of turn and that we not be labeled that way as hospice. So.
Yeah, that sounds awful. Well, that's great. And if you have any openings, you can reach out to me and I can help you connect with the people that showed interest today.
All right.
But yeah, it was great talking with you, and thanks for taking the time to answer all of our questions.
Thank you so much. Thanks for having me.
Have a great day.
You do the same. Take care.
Bye.
Bye.